Great, thanks a lot. So thank you all for having me today. This is, again, the ABC Science Collaborative. Go ahead. But there we go. So as usual, the information here is to help to be of service to school districts. But we're not here to make specific decisions nor advise specific action. And this slide does not have, but should have on it, the NC toolkit. As a reminder to all folks who are on the call, which is a really good resource, not only for schools, but elsewhere. Go ahead, next slide, please. So just a few reminders. So the ABC interacts with districts on a voluntary basis with the districts. We do have funding from pilot funding from the National Institute of Health. The faculty involved are all volunteering our time to the effort. The funding that is provided goes to pay for the staff time. We are not paid by the state, we're not paid by the county, we're not paid by the school district, and for the faculty, we're not paid for the effort at all. The data that we provide and data that comes from other studies are one part of the decision around remote versus face-to-face instruction decision. And as I've said before, I think several times, harkening back to August, not only do I not have any knowledge of staffing or the 10,000 other items that go into a school board or superintendent's decision around remote or face-to-face. It's not something that we touch on. We're here about the data. I was asked to touch on emerging science for this particular meeting because it has been presented in the press. Go ahead, next slide, please, about coronavirus variants. So several have been recently described. 117, which first started being described related to United Kingdom. 1.351, originally thought to be originally from around South Africa. But this will also here sometimes referred to as 501. And then one from Brazil. Now, as these variants have come out, there have been a number of questions around them. And it's these are, of course, unknown for certain, but we'll get into them. Transmission. We've got some data here, and it's unknown for certain, but it's thought that they're more easily transmitted. They have emerged to be the predominant strain in several counties. Early estimates on the increased transmission are around 35 to 59%. And because of how rapidly, especially the 117 and 501, emerged to be the predominant strain, it's very solid early data that transmission with these are greater. It is unknown if transmission is more efficient despite mitigation measures. Specifically, we don't have evidence that this can come off as sounding a little bit facetious, but we don't have evidence, for example, that they pass through masks any easier. the virulence. So this is unknown, but is hoped to be no different. And there's not data that the virulence itself is different between the variants. Now, because transmission is likely to be a bit more efficient, up to considerably more efficient, the virulence can stay the same, and we can, as a community, unfortunately suffer more deaths. But the virulence for any one person infected hoped to be no different, and no data suggesting otherwise just yet. Vaccine efficacy is unknown, but potentially no change. This has to do with a couple of reasons. One has to do with immunology. Our immune system is a complex environment, and immunity consists of not only antibodies, but it also consists of CD4 T cells. Think of T cells as kind of the quarterbacks of the immune system, and other components that a balance of those factors is really important. And when we design vaccines, especially around this particular organism, or this particular virus rather, we look specifically for something called neutralizing antibodies. Now, the neutralizing antibodies are something that you, if you've got the spike protein, you can, and as a reminder, the virus proteins cause for a binding or connecting to the human cell that gets locked into place. You get entry into the cells. Antibodies disrupt that lock in place. And so when we get vaccinated under the mRNA technology, those vaccines are designed for the body to develop antibodies when the protein of the virus that is responsible for docking with the cell, that protein is in pre-fusion configuration, and we then develop antibodies that block this relationship between the virus and the cell. But there's other components of immunity that are important to the equation as well, and that's why ultimately it's hard to know. But preliminary data suggest, and this is based on an early study of 20 patients, that's why we're talking preliminary. Preliminary data suggests that when we take antibodies that folks have made against the older variants, those antibodies on the petri dish, if you will, in the viral media, if you will, outside the body, those antibodies are effective and are likely to be effective within the human. So unknown for certain, but we think probably no impact on vaccine efficacy. Now, why do we get variants, and what impact might they be on school, any kind of school decisions, on any kind of policies around schools? Well, the European Union is struggling quite a bit around some of the new variants. And as a reminder, the policies in Western Europe, for the most part, have been to open without strict adherence to public health mitigation strategies within schools. And so I anticipate that there'll be a considerable problem in Western Europe because they don't have the mitigation strategies in place. Whether or not there's differences for schools in the United States where some districts are outside of North Carolina are not doing much in the way of mitigation strategies. I speculate that they're going to have considerable problems with these new variants. It's unknown as it relates to districts that don't have, that are putting in place mitigation strategies. I'm much more hopeful, however, for districts that put in place mitigation strategies. And regardless, these new variants are going to make strict adherence to mitigation strategies much more important in 2021 than they were in 2020 for schools that do make the decision to do face-to-face instruction. Now, why do we get variants, and are these going to continue popping up? And the answer to that is that viral genetic material is much more simple than, say, mammalian genetic material, human genetic material. And so there are, and in any one human, in some viral infections, you can have 10 to the 8th and 10 to the 9th levels of virus. So you have a combination of lots and lots and lots of virion and not a lot of fidelity in how the genetic material is replicated, and the theory of evolution coming together in a difficult intersection. And so we're going to see quite likely variants become a recurring story throughout 2021 and 2022. And we see it's not quite the same story with influenza, but I think a good way for lay folks to think about it is just like you need to adapt with flu vaccine every year. Eventually, we may be in a situation where we may need to adapt vaccines downstream, but that's not today, thankfully. Go ahead, next slide, please. Good. So the good news on the variants, probably not impacting as it relates to vaccine efficacy. Unfortunately, transmission is probably more efficient. Thanks.
Thank you, Dr. Benjamin, for the brief update. Are there any questions from board members at this time? Ms. Kushner.
Thank you, Chair Sutton, and thank you, Dr. Benjamin, for being with us today. You've had 2 associated papers being published in the last few weeks, so we've been receiving those from members in the community. So congratulations on that, getting all that published. But it's oftentimes some of the qualifiers, some of the context of your work is not being as broadly, the community doesn't seem as broadly aware of some of the fine points, some of which you've gone over. I just feel like I was in a biology lecture just now. But can you give us some ideas of the information sharing and ways that we can place your work in context for the everyday high school student, family, community member, because we've had your papers quoted on both sides of some of these issues.
All right, so there's strengths and weaknesses to any manuscript, and that's especially true when you don't have a randomized trial. So any kind of epidemiologic work is going to have substantial strengths and weaknesses and open to flaws. I would say taking maybe a group of flaws together and then a couple of strengths. I would say number one is some of the kind of the most concerning, which would be that these data show that we should simply reopen. You see this sometimes quoted in other states other than North Carolina, where there's not a mask mandate and there's not some of the mitigation strategies that are done here in North Carolina. And as we have said multiple times, that is a recipe for disaster. I would say number two would be it's important to note that there was extraordinarily strict adherence to the mitigation strategies. We had superintendents, school leaders, and school staff doing walkthroughs to document the fraction of people masking. We had districts set up ways for folks at the school level to report their concerns. We had superintendents and other school staff reviewing video to ensure adherence. We had lessons learned where superintendents would, based on whenever they had clusters and secondary transmission, would engage in a lessons learned process. If those things aren't in place, you're asking for trouble. I would say number three is that the data were collected when these districts predominantly were in hybrid model. I was asked this by this particular board. I know you all know this well because I seem like I got asked this a number of times. Yes, those districts have continued to collect data, and yes, some of them are in Plan A, and yes, they are having some success. But fundamentally, these data were collected in the hybrid model, and these data really apply to the hybrid model. And I think you all experienced this in December, where the data are not about, the data are fundamentally about within school transmission. So that if you don't have enough people, if your community transmission is so high that you don't have enough people for staffing and backup and things like that, that can be a real problem. I would say that and again, we don't have knowledge or line of sight onto that. And as I've said in this board meeting many times, that there's kind of the medicine of are you having secondary transmission? And then there's the human resources part around staffing. I would say another item, again, we outlined this in the paper, I've outlined this to this board before, has been around the testing was voluntary. And so testing's not 100%. We've gotten permission to go back and assess those numbers. And so we will be getting more detail on that. We're going back and forth, negotiating right now with the IRB as to what we can do along those lines. But in the current iteration, the data don't have a standardized testing, and so it's certainly the case that just like in the community, not everyone is tested. In the schools, not everyone is tested. It is pretty clear based on both clinical experience and how kind of the robust nature or the greater emphasis on contact tracing that's done in schools than in other parts of the community. Testing, if anything, is more frequent for folks in the school environment than in the community, probably less frequent than those of us in healthcare experience. But again, unknown. Some of the strengths of the work have also been discussed here before. That includes the fact that it's a substantial sample size. It's got 11 different school districts. They are from the state of North Carolina. So for North Carolina counties, there's a fair amount of applicability in the sense that the guidance from DHHS is similar county to county. Other strengths include even if only half of the participants who were considered exposed were tested, you're still, if you have a rate of infectivity similar to the source population, you're looking at still an extremely small number of within school transmission. So the job done by the districts at hand is really there to be commended. They did an outstanding job. This is by no means a zero risk environment, but it is a environment I would say to be proud of, to a much lower risk environment than traditional thinking was in July and August of 2020. The other strengths are there was a fair amount of variation in the community transmission between the counties, especially as we got into October, with some of those counties at 800 or 900 per 100,000 population for 14 days. Unfortunately, Wake is now at a higher transmission than even that, according to the DHHS website.
Yes, we've been trying hard to follow that as well. And I appreciate you underscoring the need for mitigation efforts to continue and to be vigilant along those Swiss cheese layers that y'all lay out so well. And I also appreciate that the commentary that came out in the North Carolina Medical Journal focused on the need for schools to have the resources to do those mitigation practices as well as other resources so we can serve our children. Thank you.
Yes, ma'am.
So again, Dr. Benjamin, thank you for being with us. We appreciate the information and the update, and we will certainly take what you have shared into consideration.
Great.
Thank you.
Thanks for all that. We certainly look forward to continued partnership with you all. You know, the mitigation policies that Wake County had put together. I know I told you all this earlier. We have put together as a program is expanding nationally right now. You know, multiple Wake County documents are in that national playbook and that national package that's now going out to about 10 different states across the country. So we're moving the North Carolina program into a number of different states where maybe the baseline mitigation strategies are not as strong. So I appreciate the work that Wake's done in our partnership.
We thank you for promoting our work, and you know, we're pleased with our effort, and we continue to work on it and try to improve each week. Mr. Haggard, you got to.
Yes, sir, Mr. Chairman. I know that, you know, we have limited time in these meetings, but that I know myself and several colleagues may have additional questions for Dr. Benjamin. Is there a process for submitting these questions, or is there a recommendation you would have where we could pass on some specific questions, perhaps either for addressing at a future meeting or just addressing us directly?
Let me punt that question to Superintendent Moore. She is pretty much our liaison between the board and Dr. Benjamin.
I think it would be helpful when there are questions, and they have trickled in here and there different times from board members. If you can send questions that you have to me and copy all board members so that they're aware, so in case that, so everybody knows what's being asked, then I can work with the folks from ABC Science Collaborative on how to best respond.
Great, thank you.
And Mr. Haggerty, thank you for that question. You know, part of this now is just simply a question of hours in the day.